Hello, everyone, and welcome to today's edition of Pathcast. Today is May 20th, 2025. It's another Tuesday, and I'm Rifat Mannan in California. So we are continuing with our hematopathology lecture series, and today is the 12th lecture in the series. And we are very delighted to welcome Professor Nidhi Aggarwal, who is an associate professor of pathology at the University of Pittsburgh Medical Center, where she also serves as the interim director of the hematopathology division, and she is also the director of the molecular hemato-oncology division in the department. It's our pleasure to have you with us, Dr. Aggarwal, today. And today she will be giving a talk on practicing hematopathology in the molecular era. I think it's a very relevant topic, especially for those who are practicing hematopathology and molecular pathology, and that interface is so important, as we all know. And for our viewers, please feel free to post your questions and comments on the Facebook and or YouTube chat windows, and we will pass on to Dr. Aggarwal at the end of the session. So over to you now, Dr. Aggarwal. Thank you so much for joining us.
Thank you, Dr. Manan, for this wonderful introduction. And I'm going to switch off my video once I start the talk. So that's what I'm going to do now. So yeah, good afternoon and good morning, because we are in different time zones here, to everyone. And I'm going to be talking about practicing hematopathology in the molecular era. And while preparing this talk, I wondered how I should be doing that, more case-based or more based on like what it means to do this. And I chose a certain kind of a format, and the reason for that is that whether you are molecular trained or whether you are just practicing primarily hematopathology, I think it is important to understand the molecular data. It is also understand to know molecular in a way to know what test to order, when to order, what information can it give you. So with that, okay, I'm going to start my talk. So when we think about doing molecular testing, or for that matter, any ancillary testing, there has to be a end result. There has to be a thought of why are we doing that. And the areas of application for genetic testing or molecular testing in hematopathology can be threefold. Am I doing it for diagnosis? Am I doing it to direct therapy for the patient? Or am I doing it for prognosis? And it is extremely important to know those. Many of these testings serve more than just one purpose. They are for diagnosis as well as for therapy, as well as for prognosis, but some are purely for one or the other. When you think about diagnosis, there can be two ways of thinking about like how it can be helpful. Are we confused whether a lesion is benign or malignant, or do we know what it is, but we just don't know the classification, and this is going to help us classify the disease further. For therapy, it can help in guidance of the therapy, such as in targeted therapy, therapies like targeted against mutations or certain molecular markers, or sometimes even guidance of therapy, such as if the patient has a certain genetic signature, then the patient is taken for like stem cell transplant earlier than the other patients who have a better prognostic marker, for example. So that is very helpful to get some of that information for guidance of therapy, and also for monitoring of therapy. Minimal residual disease testing, there are a lot of molecular markers that are used for minimal residual disease, and that would be an example for monitoring of therapy. Also for prognosis, we know certain genetic signatures do poorly as compared to other, even in a relatively homogeneous umbrella of diagnosis, such as an acute myeloid leukemia. That's a big umbrella, but in that there are certain types, certain genetic signatures that do better than the other. So knowing this helps you order your testing, and also um, see what should be the timeline of this testing coming back. So this is the hematology diagnostic timeline, in the sense that this is a very old slide. This is from 2013, a paper, and it shows the start of molecular testing in hematopathology, or in hematology, which started off with mostly like 922 translocation and CML, and since then has exponentially progressed. And even in 2022, there was already massively parallel sequencing, like the NGS sequencing, that was being that was already there for many diseases. And since 2012 to 2025, it has even more progressed, and we'll see some of that. In terms of spectrum of diseases in hematopathology, and you might have heard of about a lot of these diseases in the other lectures. There is like acute diseases, acute leukemias, lymphoid myeloids. There are chronic diseases such as more like lymphomas, myelodysplastic syndromes, myeloproliferative syndromes, neoplasms with eosinophilia, myelodysplastic proliferative neoplasms. This is by no means a totally comprehensive list, but this is what like your potpourri of diagnosis in hematopathology. So coming to genetic testing in hematologic diseases, what is the role? We talked about it a little bit, establishing a diagnosis, whether it is lymphoma or myeloid neoplasms, whether it is reactive versus neoplastic. That is the first step of any kind of diagnosis, and it can help you in that. It can help you in classification, it can help you in prognostic and diagnostic categories, monitoring, and developing new therapeutic regimens. When we think about techniques, and it is important to know these techniques that can be utilized in hematologic malignancies and in other diseases as well, but we are going to talk in the context of hematologic malignancies. And there are so many out there that one gets confused as to what to order and how to utilize these techniques. And that's why I thought I'll put together this kind of slides that kind of help you understand, what testing will be helpful where. So this is specifically for cytogenetics. You get karyotyping, you get FISH, you get microarray results. Karyotyping requires viable cells for tissue, viable cells or tissues for culture. The turnaround time is typically 4 to 10 days. It gives you kind of a helicopter view of the entire genome. So you can see big picture items, but you cannot see very small lesions. It does have a low resolution and slow turnaround time. FISH studies, they are done on either cultured cells or non-cultured cells, and it can be done on paraffin embedded tissue. The turnaround time is typically short, and there is a high resolution. However, you need to know what you're fishing for. So you can fish for BCR-ABL, you can fish for PML-RARA, because that is what you're looking for, in most clinical circumstances anyways. Microarray technique, this was very popular couple of years ago. Then it became less popular. We still do it in our university. We still do it in most of our myeloid neoplasms, and we think it is very helpful. But it is not done in all places. This can be done on DNA from any source. The typical turnaround time is 2 to 5 days. It has a very high resolution. It is also a full genome view, and it can also, depending on what kind of microarray you're using, it can also give you information on copy neutral loss of heterozygosities. But it will not detect balanced translocations, and it will not detect tetrasomies and the likes. So to know, what are you going to miss in these assays is extremely important to know, what kind of genetic abnormalities could still potentially be driving the disease. This is more so focused on the molecular testing, Sanger sequencing, next generation sequencing with big panels, and focused PCR testing, whether it is allele specific testing or whether it is quantitative testing for high resolution. So there are pros and cons over here. Sanger sequencing, of course, is fast, inexpensive. However, it has a very low sensitivity and requires at least 20% abnormal cells present. Next generation sequencing, it is expensive. It is slow if you are thinking about like the entire panel, but if you think about it, that you get results on so many genes, it is probably faster than doing it as Sanger. You do need a dedicated equipment. You need know-how of how to interpret these results. The single PCR testings are usually, again, more like fish. You know what you're looking for, and then you are doing those testings. So to put it in this kind of a visual way, single cell analysis is more like karyotype and FISH that will give you the results of genetic abnormalities at single cell level, whereas things like whole genome, NGS, whole transcriptome, PCR, all of these are giving you results of aggregated, it is in kind of an aggregated genomic analysis, not single cell, but the resolution is better. So it is up to a base level. And then microarray, optical genome mapping, these assays are more kind of in between the single cell and the aggregated genomic assays analysis. And this is a comparison of various genetic testing in that we can utilize. Some of it we talked about in the prior slides, such as karyotype, FISH, microarray, whole genome sequencing, targeted sequencing, RT-PCRs, whole transcriptome sequencing, and optical genome mapping. And you can see the start point or the analyte is different, across. For karyotyping, we need dividing cells. In optical genome mapping, also we need DNA from viable, fresh samples, whereas most of the other things you can do on paraffin-embedded tissue. The analytical sensitivity, again, is extremely important to know, what percentage of your cells are abnormal, and hence you can pick the right assay to order based on the number of cells you feel are abnormal. So now shifting gears a little bit, talking specifically of lymphoid malignancies and establishing clonality in lymphoid malignancies. So why do we do it? Again, if morphology is inconclusive, you want to look for whether it is a reactive or a malignant case. If you want to compare two lesions, if you have, like, for example, a skin lesion that was diagnosed as a lymphoma, there is another skin lesion that comes up, and you want to see if they are the same clone or if they are different clones. Also, you could also do like a comparison of those clonal products. It is also important to be aware of the limitations and pitfalls of this approach. So what do we look at in clonality testing? Typically, most places do a sizing assay in which we are looking at the size of the rearrangements in the B cell receptor or the T cell receptor. So a polyclonal proliferation, each clone has a different gene rearrangement, and these are physiological gene rearrangements that are happening in response to the antigens that are present in the environment. So there are physiological gene rearrangements happening in the B and the T cells, and that is what we are looking for in these clonality testing, the size of those gene rearrangements. In a polyclonal proliferation, this is a cartoon that shows that these are basically different antigens, and this kind of helicopter kind of a thing is our immunoglobulins. And so you can see that there are three different regions, the VDJ regions, and different ones combine, giving rise to different lengths. And as a result of which, you get like a polyclonal bell-shaped curve when you look at this data once this assay is done. Whereas if it is a neoplastic proliferation, it is the same gene rearrangement that is happening in all of the cells. And hence, you get a clone of the same, you get the same sized product, and hence you see a peak, a monoclonal peak with or without a polyclonal background. So that is what we are typically seeing in these studies. However, the absence of clonality, while it may confirm that this is not a malignant disease, absence of clonality does not always mean that it should be that it is not a lymphoma. And there are certain hematologic neoplasms or malignancies that one does not expect to have rearranged immunoglobulin or T cell receptor genes. For example, in NK cell lymphomas, in myeloid sarcomas, plasmacytoid dendritic cell neoplasm. So if that is in your differential, then these assays will not help you, because these may be negative since the rearrangement, the clonal rearrangement, is not in the B or the T cells. Also, there are certain polyclonal lymphoid proliferations in which you could have a monotypic population, that is by flow or by IHC, but typically you will have a polyclonal molecular study. So the limitations to clonality studies are that there is a limited sensitivity. Of course, your cells that are clonal have to be significant to show up in the background of a polyclonal population. Presence of clonality does not always mean malignancies, and this can be if there is a small population of cells in the background. They may, because it's a PCR reaction, and it will pick few of those cells, and it will start looking like a clone while it is not. The rearrangements are also not markers of lineage. So it has been shown that sometimes you can have T cell gene rearrangements in B cell neoplasms, especially the lymphoblastic kinds, or vice versa. And you can also have them sometimes in myeloid neoplasm. So they are not necessarily markers of lineage. So I mean, like, you have to get to what kind of, or to the lineage first, and then do the rearrangement studies. There can be pseudoclonality, there can be oligoclonality, and there can be false positive and false negative results. So these are just some examples of cases where it could be benign and still you could have a clonal population. And then there are certain these are other examples of what are considered to be pre-malignant or the likes, where you will have a clone. So with that, I'll show a case of a clonality where it was used in a certain context. So this was a 68-year-old woman. She had dyslipidemia. She had a submandibular mass on the left side. And she underwent some mandibulectomy. There were two lesions that were seen, and they were morphologically a little bit different. One looked more benign, the other looked more malignant. Clonality studies were done to see, one, if there is a clone present in both the sites, and if present, was it similar or not. So we typically look at the size ladder, which tells us what is the integrity of the DNA that we are looking at, and it shows that the integrity of the DNA is pretty good. So up till 400 base pairs, you are able to amplify the DNA. These are the different tubes that we run for the B cell clonality. And in framework 1, these are the two lesions. The top one is one lesion, the bottom one is the second lesion, and there is a smaller, plot of the polyclonal control that we run. So the first tube, it kind of shows that there is a kind of an accentuated peak over a polyclonal background. So this may be possibly a clone, but a low level. And then the second lesion did not really have that. This is the second tube that again shows that there is a good, kind of a monoclonal peak that we can see, maybe in a polyclonal background. And then the second lesion does not really show it. The third tube shows a peak in the polyclonal background, and you see kind of that similar peak in the second lesion. However, it's not that prominent as compared to when you're comparing the first lesion. This is the kappa. This is the fourth tube that we run, and there is a monoclonal peak here. I think my other other plot disappeared, but that did not show this monoclonal peak that is at 146 base pairs. The second peak at 149 base pairs is actually a non-specific peak that we see in our polyclonal background. And this is kappa deleting element, our fifth tube that we do for B cell clonality. Again, what you're seeing is there is a clonal peak at 380 base pairs that you do not see with the second lesion. And this is the polyclonal background, which does not show this peak. So in the end, this is kind of the result of lesion 1 versus lesion 2. Most of the peaks that were seen in lesion 1 were not seen in lesion 2, except for this one peak that was seen in FR3, or the third tube, which was a little accentuated peak. Now, and T cell clonality was also done, which was kind of polyclonal. So based on this, there might be a small population which is getting dampened by more polyclonal background in the second lesion, and the only place where it is showing up is FR3. However, this is not enough to say that this is involved by the neoplastic process that is happening in the lesion 1. There is another way of looking at clonality, which is actually doing sequencing. So there we are assuming that if all of the rearranged immunoglobulins or the T cell receptor have the same size, then we are assuming that it is coming from the same clone. However, it could be by chance that the size of two separate clones is same. So to overcome that you could actually sequence once that product is identified, that gene rearrangement is identified, you can actually sequence it. And that is the concept behind clonoSEQ or other sequencing assays for clonality. Because you can actually sequence it, you can also do minimal residual disease testing in that way. And it is now FDA cleared for at least multiple myeloma and B lymphoblastic leukemias. And some of our clinicians will do it routinely when flow cytometry is not helpful. And this is just showing that the data of MRD clonoSEQ versus MRD flow is quite consistent in identifying these minimal residual disease clones. And this is something that shows that finding these minimal residual disease clones is important, and patients who have less than 10 to the minus 5 cells present do much better than the patients who have greater than 10 to the minus 5. So another way to look for clonality in lymphomas is looking for chromosomal translocations. And while I'm saying lymphomas, of course, chromosomal translocations and fusions can also be seen in other types of hematologic malignancies, and we'll come to that. But here, in the context of lymphomas, there are some very common chromosomal translocations that can be evaluated for. And if you find these, this is also a way to establish clonality. So, we've all learned about follicular lymphomas having translocation 1418, that is translocation between IGH and BCL2, Burkitt lymphoma demonstrating MYC with IGH, and so on and so forth. There are also translocation in T cell lymphomas, most well described in ALCL, the NPM1 ALK translocation, and TPLL with the inversion 14. And some more relatively recently described ones, in classic Hodgkin lymphoma, etc. So, even if we know that it is a lymphoma, we can further use it to describe which kind of a lymphoma. It is using these FISH assays. In large B-cell lymphomas, we typically do FISH studies for MYC, BCL2, BCL6 to identify if it is a double hit or a triple hit lymphoma, which carries a worse prognosis as compared to other large B-cell lymphomas. So this is a study that talked about large B-cell lymphomas, and it identifies cases of double hit and triple hit. And they definitely do more aggressive. They are more aggressive, and they are classified as high-grade B-cell lymphomas. But there are also certain cases that otherwise look like diffuse large B cells, and have isolated MYC translocation. And it is still classified as a diffuse large B-cell lymphoma in that scenario. And this is just an image of FISH study that, depending on whether you're using a break-apart probe or whether you're using a dual fusion probe, you could read it one way or the other. So if this were a break-apart probe, then this red and green signal broken apart would be the abnormal one. If this was a dual fusion probe, that means maybe the red was with IGH and the green was with BCL2, then this fused signal would be the abnormal one. The other way of looking at clonality and to find specific molecular signature is to do next generation sequencing testing. For a very long time, diagnosing lymphomas that were CD5 and CD10 negative was extremely difficult, and to further classify them. And then we identified MYD88, L265P somatic mutations with Waldenstrom macroglobulinemias. And these mutations are identified in greater than 90% of the cases of LPL. And now this can be used as a marker almost for lymphoplasmacytic lymphomas. However, none of these are like specific. They can be seen in other circumstances, but in the context of a small B-cell lymphoma, which has a more like a bone marrow-based morphology, finding a MYD88 becomes very specific. Another mutation that is very kind of helpful in hematologic malignancies is a BRAF mutation. It is identified in most of the typical hairy cell leukemias, almost up to 100%, although there is a small subset that is not BRAF positive. But it is also seen in diffuse large B-cell lymphoma, in Langerhans cell histiocytosis, Erdheim-Chester disease, a very small percentage of multiple myelomas, and rare CLLs have been reported to have BRAF mutations. And this helps not only in the diagnosis, but also in clinical trials and treatment. Hairy cell leukemia can be treated. It's typically a good a good treatment against hairy cell leukemia, but you do have relapsed and refractory cases that could be helped by BRAF inhibitors. This is an example of an Erdheim-Chester disease in the long bones, and you can see all this dark color is the disease in the long bones, and this is before BRAF inhibitor, and then after BRAF inhibitor in 1 month and 4 months, you can see how well the lesion has responded, and similarly in the patient too, it is similar response. There is also molecular classification of diffuse large B-cell lymphoma. This was a paper that was published in 2020. And what it shows is that, typically what at least most labs are doing is doing, some kind of a algorithm to state whether the diffuse large B-cell lymphomas are activated B-cell type or germinal center type. And then there are also some cases that remain unclassified based on the usually people are using immunohistochemical markers to do this, and less so gene expression profiling. But when you can look at these, that once you have that, you can further classify it based on molecular, based on a number of genes into, in this paper, they classified it into 7 different categories based on the mutations that are present. So this MCD, for example, has the most common mutation in this group was the MYD88 mutation. And this is important because because of potential therapeutic targets, potential other prognosis, like these tend to be more aggressive, these tend to have a poorer prognosis. And then there are other categories based on Notch1 signaling, they called it N1 and TP53, the A53 group. Then in T-cell lymphomas as well, you could do T-cell gene rearrangement, of course, to support the diagnosis of T-cell lymphomas, because T-cell lymphomas in general are harder to diagnose, and they are rarer to come to your bench. So, T cell gene rearrangements can be studied, can be done to support that diagnosis. Also, certain gene rearrangements, like we talked about, like the ALK gene rearrangement, it is seen in a subset of CD30 positive ALCLs. However, they can also be ALK negative ALCLs, and in that circumstance, you do the DUSP22 IRF4 gene rearrangement and TP63 gene rearrangement that can be seen, and that can help in the diagnosis of ALK negative ALCLs. And then prolymphocytic leukemias, we talked about the inversion 14, that is, pathognomic of this diagnosis. There are other molecular signatures that have been described, for example, in lymphomas of the follicular helper type, like AITLs. There is a genetic signature that is typically identified with these lymphomas that includes mutations in genes such as TET2, IDH1, IDH2, RHO-A, and DNMT3A mutations. And these help in cases that are suspected AITL versus other PTCLs. Again, STAT3, STAT5B mutations are recommended in circumstances for diagnosis of large granular lymphocyte leukemia or NK cell leukemias. And STAT5B can be associated with more aggressive subtypes. So this is very helpful in cases in which there are patients who have rheumatoid arthritis or something, and they have an expanded TLGL population, and then one wonders at what point do you start calling it as a TLGL leukemia? And while there are criterias, it becomes very hard to actually utilize those criterias and call it the large granular lymphocyte leukemia. However, if you find the mutations, that becomes very helpful. So then changing gears and coming to acute myeloid leukemias. In the past, it was always blast greater than, it used to be 30%, then it became 20%. And now we have two classifications, the WHO classification and the ICC classification, and they are a little bit different. And that is why there is an asterisk on there. But for the purpose of this lecture, maybe like we'll just leave it like that, blast greater than 20%. Of course, we haven't we don't know the lineage yet. So it could be ALL, acute myeloid leukemia, or leukemia of ambiguous lineage. You look at the history, molecular cytogenetics data. If there is recurrent genetic abnormality, then it is AML with recurrent genetic abnormality. For this, there are different criteria in the two classifications. In the WHO classification, you don't necessarily need a percentage to call it AML. If you have the recurrent genetic abnormality, ICC classification still requires greater than 10% blasts. If the patient has prior MDS or MDS related cytogenetic or molecular abnormalities, so molecular abnormalities are somewhat new in this category, and these are listed here. You call it AML, which is myelodysplasia related. And if you have none of these, then it becomes AML NOS. And for CEBPA and BCR-ABL, you do not require 20, you still require 20% blast percentage. And this is like a kind of a list for the recurrent genetic abnormalities. And as you can see, this is in the 5th edition, and this is the ICC classification that is currently being used. And this list has grown from being just 2 or 3 translocations to so many translocations. And it is important because these translocations, to look for these translocations, again, coming to the molecular side of it, to look for these translocations can be difficult if you're using like a dual fusion probe. For example, if your lab is using a dual fusion probe for PML RARA, and actually the partner for RARA is not PML, then you may miss that translocation in a dual fusion probe. So a good idea would be to look at a break apart probe in that scenario. And there can be multiple partners, and break apart probes usually help with that. However, some of these translocations can also be cryptic. And hence it becomes important to have another technique in which these translocations can be identified. And since this is a growing list of translocation of fusions that can be identified, other techniques such as whole transcriptome or some kind of RNA sequencing would be helpful. It is also helpful when the disease is definitely like an acute myeloid leukemia, but you do not have a driver mutation. In addition to all those translocations, there are also, of course, mutated genes in AML. This is again one of the older papers or first papers that was describing a subset of genes that were seen higher than expected mutation prevalence within acute myeloid leukemias. And I think this list has grown. However, the most important ones are still here. And even when you classify the AMLs based on their translocations, like the 517, the 821, the inversion 16, the prognosis of these could be based on other co-mutations that are identified. For example, with NPM1, we know that if you find the FLT3, that is supposed to be a poorer prognosis. Even in the NCCN guidelines, now there is the workup of an acute myeloid leukemia includes molecular analysis for lesions that allow risk stratification per the ELN guidelines. And they have named a few. However, most of the times you want to do a bigger panel so that you can tell about the prognosis of the disease as well. And this is ELN risk stratification by biological disease factors, and it's split into favorable, intermediate, and poor or adverse risk. And you can see that based on the genetic abnormality, it can be placed in one or the other, and therapy would depend on that. Then again, going through this, and there are 4 slides on this, and we don't have to read through them at all. This is from the NCCN guidelines. What I'm just trying to show you over here is that based on those ELN guidelines, based on whether it is favorable, whether it has a FLT3 mutation, whether it is poor, the recommendations for therapy are slightly different. So again, we don't have to go through all of this, but like with TP53, there is a different protocol that is followed. With IDH mutations, there is like different protocol that is followed, including with the IDH inhibitors. So these are some of the FDA-approved targeted therapies based on molecular analysis. So FLT3 inhibitors are FDA-approved, IDH inhibitors are FDA-approved, etc. The other very important reason for doing molecular studies is MRD testing, like we spoke about. The most commonly available molecular MRD testing is for NPM1 mutations. These are relatively stable mutations that can be followed. You do not want to pick a CHIP mutation to follow. So NPM1 would be a good one. RUNX1 fusions, these can be followed for minimal residual disease, the CBFB mutations, and the PML-RARA, and of course the BCR-ABL as well. You could do it by flow or by NGS. And the timing for MRD is important. It is usually done after induction or after transplant or other times when clinically indicated. It is important to know the sample type that should be pulled for these MRD testing, especially for the NPM1s, peripheral blood. Most studies have been done on peripheral blood. But usually you want, if it is the bone marrow, you want the first dedicated pull for flow cytometry for minimal residual disease or for any other minimal residual disease testing. So moving on, in diagnosis of MPN, you look at the patient's picture first, whether the patient has leukocytosis, erythrocytosis, or thrombocytosis. You exclude the reactive causes, and these are most of your big ticket items in the diagnosis of myeloproliferative neoplasms. And then this is if you were to do these molecular testings one after the other or in a sequential manner, JAK2 would probably be done first because many of these are JAK2 positive. Polycythemia vera, greater than 95% of them will have some kind of a JAK2 mutation. So V617F, if that is positive, then of course it is polycythemia vera. And if it is clinically and morphologically also looking like a polycythemia vera. If it is negative, then you look for JAK2 exon 12 mutations. And most of your polycythemia veras will have one or the other JAK2 mutation. And if it is not JAK2 positive, then you almost want to go back to your findings on the bone marrow and clinically and see what is going on with the patient and is it truly a polycythemia vera or not. For ET and primary myelofibrosis, again, you would start with the JAK2. These days, we do kind of a next generation sequencing, a more comprehensive panel. So we are not doing these in a sequential manner. But this is just like if you were to do it sequentially, JAK2 is more common. So you would start with that. If that is positive, like, if based on what the clinical and the morphological look of the bone marrow is, it's either an ET or a PMF. If that's negative, you do a CAL-R exon 9 mutation analysis. And if that is negative, then you do a MIPL assay. And again, like you could have a triple negative ET or a PMF, more so a PMF. And that is where a more comprehensive testing helps. CML, of course, BCR-ABL, that is disease defining for CML in the context of myeloproliferative neoplasms again. I mean, BCR-ABL can also be seen with acute lymphoblastic leukemias as well as acute myeloid leukemia. So in the context of MPN, BCR-ABL is disease defining for CML. And if it is negative, then you do other, again, you do a comprehensive assay. It could be CNL or it could be something else. So Philadelphia chromosome is, we all know that it is 922 translocation seen in CMLs, and it leads to a constitutively active tyrosine kinase activity. And this is just a case that I thought that I'll show here. This is an 81-year-old male with leukocytosis with left shift and anemia. And two bone marrows were done, one in 2022 and one in 2024. And the reason I bring this case is because it shows various techniques that were done on this one particular case. And it shows, how you will identify what and how that can be used in the molecular sense. So this is a bone marrow that was done in 2022, the top left corner, and you see that there is a left shift in the myeloid maturation, many mature neutrophils seen on one end, and then there are maturing forms, myelocytes and metamyelocytes seen in the other, and very few erythroid precursors. Biopsy in 2022 was very hypercellular for this 81-year-old person. The cellularity is probably 80% or more. And in 2024, basically, it presented as blast crisis. There are multiple blasts over here. The karyotype always showed, and if you look at the arrows, it shows the 922 translocation that was identified. FISH studies also identified the BCR-ABL fusion, and there is an extra fusion, so there was an extra copy. Microarray actually does not show the fusion at all. And if you remember in my first slides, I talked about how microarray will not pick up a balanced translocation. So as long as the genome is balanced, it will not pick up the translocation unless there is a small deletion associated with the translocation. So that came back normal. And interestingly enough, in this patient, the PCR actually did not pick up it did not pick up BCR-ABL at a level that one would expect in a diagnostic marrow that has either not been treated or has blast crisis. So you can see that the BCR-ABL major transcript was positive at a very low percent of 0.02% international standards, and minor was negative. So that was kind of perplexing that you're seeing it in karyotype, you're seeing it in FISH, but you cannot pick it up by qPCR reaction. So microarray was expected that it will not be picked up. So, but when you look at it, there can be various transcript types of BCR-ABL. There is a shorter version, or the 190 kilodaltons, which is typically seen in acute lymphoblastic leukemias. There is a 210 version that is seen typically in CMLs, but there is also a 230 kilodalton transcript type that can be seen and that is harder to detect. So we did whole transcriptome sequencing on this case, and we actually did identify the 230 kilodalton transcript. So using this clinically, we know that our assay of qPCR that looks for 210 kilodaltons or the 190 kilodaltons will not be good enough for this patient. So this patient would require something else for doing a minimal residual disease testing, and our assay will not be good enough. And these are just NCCN guidelines that talk about how the patients of chronic myeloid leukemia should respond to the TKI therapy. And you want like at least threefold reduction. If you do not get this kind of a reduction in the time periods that are mentioned here, you want to consider changing the TKI and also doing further testing, further molecular testing to look for possible resistance. And this kind of shows, what therapy should be done for what kind of mutations that are identified in the ABL1 kinase domain. Then we kind of went over the other myeloproliferative neoplasms. A subset of them will be JAK2 negative, and you should do CALR mutations in that, and MIPL. And this is just a schematic diagram of showing that exon 9 of CALR. So just finding the CALR mutation is not enough. You can see that there is prognostic significance to the type of CALR mutation as well. So, what kind of mutation is identified, even within the gene, what type of mutation is identified. And then if it is triple negative, which means it is negative for JAK2, MIPL, and CALR, it usually has an inferior leukemia-free survival. And then the other mutations also make a difference in the prognosis. Then sometimes patients have, we encounter cases in which the disease is not overt, and these are clonal hematopoiesis. And so when do you call it MDS? So for MDS, you require clonal mutation or clonal karyotypic abnormality, dysplasia, as well as cytopenia. If one or the other is not present, then it falls into other categories, such as idiopathic cytopenia of undetermined significance, wherein you do not have any clonal abnormality or dysplasia, but the patient has cytopenias. And this could be because of many secondary causes. Idiopathic dysplasia of uncertain significance, wherein you just have dysplasia. Clonal hematopoiesis is when you have mutations, but you don't have dysplasia or cytopenias. And then clonal cytopenia of undetermined significance is when you have clonality, when you have cytopenia, but you do not have dysplasia. This is again for myelodysplastic syndromes. Fortunately, the gene list is pretty similar across the myeloid neoplasms. So, and it is similar genes that you are looking for, and mostly they mean similarly as well in terms of prognosis. I think the biggest help we've gotten is in the diagnosis of CMML. CMML, there used to be monocytosis, and in the past, you would say that monocytosis can be seen in various reactive causes, and it had to be persistent for 6 months without a known cause, which was very hard to establish because sometimes these patients were hospitalized, and there were other reasons for monocytosis as well. But now we've seen that the vast majority of CMMLs actually do have mutations, and they have certain signatures. For example, they typically have RAS-like mutations, they have biallelic TET2 mutations, they have SRSF2 mutations, and all of these help you diagnose CMML at a much earlier time point. There are also germline mutations with predispositions, and many times we think of germline mutations in myeloid neoplasms. We think of these individuals being younger, and to think about germline mutations when patients present with myeloid neoplasm at a younger age. However, you'll see that some mutations such as DDX41 can be identified in mid to late adulthood. And so it is important not to ignore in this circumstance to look for germline mutations. And there are morphologic criteria such as the morphology of the megakaryocytes and finding vacuoles in the other lineages to point you to that diagnosis. And it is important to identify this because if the patient were to go to transplant, you want to know if the patient is carrying a germline mutation to identify a donor for this patient. So we are at 12:52. So I'm going to quickly close this session so that I can take some questions. But B lymphoblastic leukemias, again, these were much shorter lists of chromosomal abnormalities and molecular abnormalities that have kind of exploded at this point. And based on whether the patient is a pediatric or an adult patient, the milieu of the molecular or the genetic abnormalities that you find can be very different. And the kind of testing you want can be very different. So this is a little flow chart that could be used for BALL diagnosis. And different places can do it differently. What we follow is we do karyotyping. Of course, we have certain cytogenetics fusion fish assays that we look at. We do microarray studies to look for pseudo hyperdiploidy. And then if none of those is positive, we send it out for RNA sequencing and look for a fusion product there. There are also immunophenotypic screens that have been described for different kinds of fusions. And this is the reason why we do it, because there are TKI drugs and they are targetable fusions that can help the patient in therapy. Similarly, for TALLs, there is much less out there for molecular and genetic testing on T lymphoblastic leukemias. However, the list is growing for this as well. That's my last slide. So thank you everyone for your attention. I'll take any questions now.
Thank you so much, Dr. Aggarwal, for this very comprehensive overview of such a broad topic. And you have really covered so many entities and different ways to interpret molecular testing. I have a few questions that I saw. Can you stop sharing, please?
Okay. Okay, I still have to find. Stop sharing.
Yeah.
Okay, no, check. Can you kick me out because I can't see?
Oh, yeah. Maybe that's a better idea.
Yeah, I don't think I can see how to stop.
Okay. Yeah.
Oh yeah, I see it. Okay, I stopped sharing.
Okay, perfect. Yeah, so there are a few questions. Let me read some of them for you. One question is that you have mentioned T-cell lymphoma diagnosis is challenging, and including with molecular methods. And can you elaborate on that more a little bit? And what are your suggestions in such situations, and especially regarding extranodal T-cell lymphomas, and how you think that molecular testing can be helpful, and your suggestions on that? I think that's one question from one of our viewers. Thank you.
Yeah, I mean, definitely T-cell lymphoma diagnosis is extremely challenging. And what I would say is that not to rely on any single technique completely. So it has to all come together for that diagnosis. So there are certain things, for example, if something is ALK positive and it is CD30 positive and it has T cell markers on it, then I'm sure we're not talking about those cases that are simpler. But sometimes, you have cases in which even when ALK is positive in a CD30 positive lesion, it may not be a T cell lymphoma. It may be something else, like not a lymphoma altogether. So I think not to rely on a single technique is very important. So if you start with the morphology and the clinical history, and if the morphology looks like it should, like, it is abnormal, then go to the second phase of immunophenotyping it, flow cytometry. Flow cytometry is a very strong tool to pull out small abnormal clonal populations, and you are able to actually look at them, um, in even if it is like, it has a lot of polyclonal in the background. And then to utilize your molecular in the right way. If you were to start doing molecular in all of the cases, you will find clones that you will not know the meaning of, because it as we are doing more and more ancillary studies, we are finding these little clones that are present in that do not have any significance. So I would say not to rely on single technique, but to use it in a very in a very intelligent way.
Right. Thank you again. Actually, there is another question from one of our viewers, Dr. Aaron Orbach, and I want to mention now that he has, we are really thankful to him. He has been instrumental in organizing the lecture series on hematopathology. So his question is, so do you do a lot of T-cell rearrangement studies on skin lymphomas?
Yes, I mean, I think like, so our derm path colleagues are the ones who get most of these biopsies, and the threshold to do T cell rearrangement studies is very low, especially in skin lymphomas. Again, I would say that we don't automatically diagnose it as a lymphoma. If the T cell gene rearrangement comes back positive, it has to be in the context. But especially for skin lymphomas, we do T cell gene rearrangements. Our threshold is very low to do it on those cases, because there can be multiple mimics of lymphoma, especially in the skin. But it has to be in the right context for it to be diagnosed as such.
Right. So, like, I mean, again, staying with T-cell lymphoma, because that question is relevant to us as well. I mean, there had been a few instances in tubular, like, GI tract and in liver, when a patient had previous diagnosis of T-cell lymphoma, and then there were some lymphoid aggregates, and I at least remember one or two cases which was very challenging. I mean, when I was keeping track, because especially in these situations, like, I mean, do you have any experience that, I mean, if the things are like, or at the end of all your tests, also it is not being able to resolve, because, that morphology can be very subtle for those lymphoid cells. So what do you do then, practically?
Practically, I mean, again, like, you have to look at the whole picture. And I mean, like, before I answer your question, I do want to answer this one question that asks, it seems molecular testing has contributed to splitting. Are you in favor of it, or are you more of a dumper? I think like that is what I'm trying to kind of state, that you have to use molecular. I'm definitely not a dumper, but but you have to use it intelligently. That is hopefully the message that I have been trying to give, that you have to know what you're doing, what is the sensitivity, what kind of assay you wanted, and in that context, doing molecular testing. So coming back to your question about, subtle infiltrates in the GI tract that might be clonal, what do you do with it? So there is a whole concept of indolent T cell lymphoproliferative disorders. And, maybe it is one of those, or maybe it is the background T cells that are picking up, and this is not even relevant. So I think the whole picture has to be taken into account. If something is difficult to diagnose, then being brave and diagnosing it based on one assay is not a good idea. Even if the patient has to get a few biopsies, it will declare itself. So that is what I would say, um, in kind of like conclusion to this whole concept of how to use molecular studies. Not to use them in isolation, but to use them in order to support your findings.
Thank you. I think that's very helpful, Dr. Aggarwal. So there are a couple of more questions. One question is that what are some pitfalls that you have encountered in interpreting molecular data that contradicts morphology or flow cytometry?
Yeah. So I think one of the pitfalls is that, what is taken for molecular may not be representative. Your morphology and flow is on one part of the tissue, whereas the molecular gets done on the other part of the tissue. Um, or the sensitivity of the assay. Flow is more robust in picking out an abnormal population that you can phenotype, and by multiple markers that this is an abnormal population, whereas that population may get diluted out with many more polyclonal cells in the background, and that may come back negative. So I think that is one pitfall. The other pitfall is that you could have these small clones which you are quote unquote not supposed to diagnose as a lymphoma. For example, in cases of eosinophilia, you can have a small abnormal T cell clone which is called lymphocyte variant eosinophilic syndrome. And then you can also have small T cell clones circulating, which are called as clonal T cells of undetermined significance. So you might find all of these, and you might even get molecular data as clonal. But again, that should not be used in isolation. Um, those are kind of the pitfalls. I mean, sometimes the background. So if the cells are very few, like if there are very few B cells or very few T cells, they can be picked up in PCR reactions and can present themselves as clones, which is not even the prominent lesion. So I think that can be important. Things like classic Hodgkin lymphoma typically should not have a T cell clone, and a B cell clone can be present but may not be present depending upon the amount of abnormal cells that can be seen. So I think those are some of the pitfalls in interpreting the molecular data um, that can contradict morphology and flow. But you have to put everything together.
Right. Thank you again. So there is another question that I found, and I think quite relevant, because we are talking about practicing hematopathology in the molecular era, and our audience is very diverse. And so and now that with every new WHO edition and all, like there are molecular signatures that are defining entities for diagnosis, and of course with treatment implications. But I mean, what is your suggestion, or what is the drawback you think that is bringing to people where, like they may not have the facility to do all the testing? That is the reality in many places. So what do you suggest to our colleagues who are facing such situations where they are not able to diagnose just because they don't have the, facilities to do that? What do you suggest for them? Any advice? Because it's fast changing, especially in hematopathology, right?
Yeah, I mean, like that is definitely a problem. That is definitely a thing that comes up because not every place has the capability or the resources to do all of these testings. I mean, even bigger academic centers send out a lot of these assays because you do not have either the volume or the expertise to actually do the testing and to interpret it. So this is a real issue for sure. What is my advice for it? I think like to be efficient and economical, to see what will change the management of the patient and definitely get that part done, whether you do it in-house or whether you send it out or whether you recommend it to the patient to be done elsewhere. I think what will change the therapy or the prognosis of the patient, most importantly therapy of the patient, I think that is what we should aim at least trying to get to. If it isn't going to change the therapy of the patient, then it is less important in some ways to tease that out. Thankfully, like the genetic testing overall, like the costs are reducing, and hopefully they will continue to reduce. And also to use like immunohistochemical kind of surrogates for things that are available. For example, NPM1, there is an immunohistochemical marker that you could do for looking for that mutation. TP53, you could do an immunohistochemical marker to look for that mutation. I mean, it's not 100%, but it is good. So, I mean, like, those could be other ways of getting around molecular testing if possible. But definitely looking at, what is clinically important and how will that help the patient and getting to that part.
I think that's a very practical suggestion. Thank you so much for bringing that up so that, I mean, our colleagues are also aware that how to handle situations like that. So staying with that, because like, I mean, which is a broad topic today that molecular applications, so and which is definitely more and more relevant in hematopathology practice. So what is your advice for the trainees? Like, I mean, do you think that it is very essential for current trainees in hematopathology to learn molecular testing, and maybe like not everybody is doing molecular pathology fellowship, right? So and then there are trainees in different parts of the world also. Do you have any advice for them that how the trainees should learn molecular aspects of hematopathology?
Yeah, I mean, I think that's a very good question. I think it is imperative. Actually, it is essential to understand molecular testing if you are a hematopathologist. And it's not restricted to hematopathology, but since we are talking only about hematopathology, I think it is extremely important for one to understand it, and extremely important for one to, I mean, you don't need to know how to interpret the data, but you do need to know what you want, because if it's almost like garbage in, garbage out. If you don't know what you are ordering, you'll get a result that you would not know what to do with. I would recommend trainees to look at the cases also when these results come back, and to integrate it into those morphologic assessments that were made, and to see if they can get to a diagnosis at that point, and not to leave it at the morphology stage, and like, ignore the molecular and the genetic data. Because once you start practicing, this will become a reality when these molecular and genetic assays will come back, and you will need to explain it to your clinical colleagues as to what this molecular data means. And we cannot be practicing any specialty in a silo. So um, we have to know this molecular data, or what these molecular results mean. Whether you do a molecular fellowship or not does not matter.
Right. Thank you again. And I think before we conclude, there is one question that keeps coming all the time, and it's very relevant for all of us, is the question about integrating AI. So what do you envision about, like how AI is going to be integrated into, like, I mean, molecular hematopathology or interpretation of a molecular diagnosis? What has happened so far in your experience, and how do you envision it, especially in regarding molecular pathology? Yeah.
Yeah, I mean, I think we are in a time when all of these new things are coming up, and they'll probably make getting to a diagnosis, or putting everything, again, everything has to be used intelligently. If you don't use it intelligently, then you'll probably fall in a pitfall. But I think the AI can be used for a multiple of different ways in assessing the molecular, and in assessing molecular in context of hematopathology. So in molecular, it can help you with when you have, like, variants. It can help you look at different data points and see whether it is pathogenic or not pathogenic. Hopefully there will be a time, there is already moved towards it, but hopefully there will be a time when the amount of work required to classify these variants will become less, because of AI and because of learning. Um, Also, the use of, like, your brain can only put so many connections together. Hopefully, with AI, there can be patterns, or there can be signatures that are defined, and you can see. And if you input your morphology and your immuno with the right set of um, mutations, it'll probably give you a better, classification or help you in classifying the disease further. So I think that's how AI can be integrated and can be useful in the future.
That's great to know, Dr. Aggarwal. And I think these are all the questions that I found online. And thank you once again for this excellent talk on this very broad and very important topic. Whoever is practicing hematopathology, they cannot ignore it. And there are so many different utilities and nuances in utilizing molecular methods. And as you have mentioned, and hopefully we will have you again for a future session in the future. And then thanks once again. And there were so many viewers, special thanks to them for joining from different time zones. And my request to the viewers to follow Pathcast on different social media platforms. And you can scan this QR code also that will take you to the YouTube channel so that you can stay updated as well with the upcoming lectures. And in fact, we are staying with the hematopathology series, but because the many trainees in the United States are appearing for board, so we are organizing a board review session that is very soon. I think day after tomorrow. That's on May 22nd, and our speaker is Dr. Kamran Mirza. So he will touch on few relevant topics that are important for the trainees. So hope you can join and learn from the session. And thank you again, Dr. Aggarwal. Thanks so much for joining us today.
Thank you.
Thank you.
Okay.